Hello. Very pleased to welcome everyone to another episode of Global Health Insights. Today's episode is on global surgery. Very happy to welcome Dr. Dhananjaya Sharma and Dr. Key Park. And we're going to focus on global surgery, why now, what's at stake, what are the barriers and opportunities, and the role of innovation and the future of global surgery. So I think it'll be a great and interesting episode. Before we get into the subject matter, you guys are both surgeons, but why don't you say a little bit about yourself and your career, just in a few sentences, Dhananjaya, and I hope you don't mind if we use first names here, and you should call me Peter. Dhananjaya, do you want to say a little bit about where you are and what you've done and how you got interested in global surgery?
Yeah, thanks, Peter, for having us. I'm a retired professor and head department of surgery from a government medical school, which is exactly at the geographical center of the country, India. And for your question, for the last couple of decades, I have focused on affordable solutions in global surgery, who are contextually correct and very affordable, so they can be used even at the grassroots level. And your point about how I got interested, you don't get interested in global surgery. It embraces you. You get sucked in. So it was the other way around. So that is my couple of sentences. Key, your turn.
That's great. And Dhananjaya, you're a general surgeon, right?
I started as a general surgeon, then I started the first gastrointestinal surgery unit in central India. And once I had successors who were operating as well, if not better than me, then I could focus all my energy on global surgery, the part where I spoke about affordable solutions.
Great. Thank you, Dhananjaya. Welcome. And Key, over to you.
Sure. Well, first, let me say thanks, Peter, for organizing this podcast and showing interest in global surgery. I really appreciate that. And I also think it's wonderful that you invited Dhananjaya to this podcast because I know he's a watcher of global surgery from high level, and he's published a bunch of commentaries about it and, when appropriate, critical of what we're doing. So I think this has been an interesting conversation. As you mentioned, I am a surgeon, neurosurgeon by training. I worked overseas for about 8 years, just teaching, and then came back to U.S. I did a master's in public health and then fellowship in global surgery at Harvard. And I stayed on as a faculty at the program in global surgery and social change at Harvard Medical School. I'm the director of policy and advocacy. And what that means is that I work with WHO, the resolutions and implementation, but also with member states, the ministries of health around the world, mostly in the developing world.
Great. Well, thank you, and welcome again to both of you. So let's get into it. The first question I have for both of you is, what's at stake with global surgery and why now? The global health system is undergoing its biggest transformation in 25 years, at least 25 years. That causes a lot of dislocation. It causes some opportunities. But what's at stake with global surgery, and why is global surgery particularly relevant now at this time of very, very radical change in global health? So I don't know which one of you guys wants to go first. Dhananjaya, do you want to lead us off?
Yeah, okay. Global surgery was always a challenge, financially, logistically, and now the recent upheavals in the funding from the top Western countries, they have taken a hit. So the challenges have become more acute now. So that is one of the reasons. And it has been a decade since the Harvard Group, Professor Meera and colleagues, they published that landmark paper. So everybody, wants to look back, assess what we have achieved in last 10 years, and one decade has gone. What is the second decade going to bring us? Where we are, how much we have been able to achieve. So a lot of introspection everywhere, whether in the global south or in the global north. Everybody is introspecting and, trying to refine how we can do better. So that is why the focus is on global surgery, the second decade.
Great. Key, what would you say as a lead off? And I'll have some follow-up questions for both of you based on what you've just said.
So yeah, Dhananjaya made a referral to the Lancet Commission on Global Surgery report. If I don't have a few numbers from there, I'll take some heat from my bosses. So 5 billion, more than half the population of the world do not have access to timely, affordable, and safe surgical care. 34 million operations each year are not being done when needed. And we estimate almost 17 million people may be dying as a result of not being able to access surgical care when needed. So that's sort of the big scope, right, of what we're dealing with. But you said, now, So 10 years has passed. A number of countries, 35 now, I think, have developed national surgical strategies and plans to build out their surgical services, but they're struggling to implement it. And the other thing is just taking a much higher perspective. Healthcare doesn't typically go backwards. It develops and it progresses over time. And we've focused on infectious diseases, last few decades. Peter, you know this very well. And as health systems have grown up, even in developing countries, surgical care is really the service that I think everybody is looking to cross over, right, to meet that challenge. So I think we're sort of at the crossroads of global development, and then surgical as a care is really that challenge that we're all facing.
Great, thank you. And let me ask you, Key, a couple of follow-up questions, and then Dhananjaya, I've got a follow-up question for you too. Key, you mentioned 17, 18 million deaths, unnecessary deaths a year from lack of access to surgery. There's about 60, 65 million deaths a year in total. So that's a very big number. And I guess my question is, how many of those 18 million lives or deaths could actually be averted with access to global surgery? You said about half the world's population lacks access, and I'll come back to that in a second.
Yeah.
But if everybody had access to global surgery, how many of those 18 million lives could be saved? Because some of those lives could be saved, some of those lives couldn't be saved. So it's not the same as the live saved number.
Well, I knew you were going to ask me this, and I wish I had like a really good answer for you. Well, we just can't. We haven't analyzed, what would happen if we were to able to provide surgical care to all who don't have surgical care, and then what would be the consequence in terms of lives saved? I really don't know. So if we're saying 17 million people are dying each year as a result of not receiving surgical care, this is different from the 134 million operations that are needed, which is not all of those are life-threatening diseases, right? But the actual deaths, we estimate 17 million. And that's obviously more than HIV, AIDS, TB, and malaria combined, right? I think that's a thing we're at 3 to 4 or 5 million deaths a year. I don't know, Dhananjaya, help me out here. Do you think maybe half of those lives could be saved if there's sufficient access to timely, affordable, and safe surgical care? Can we save, let's say, 8 million of those 17 million people? I'm turning back to you because this is a very conservative 50% saved.
I have a slightly different take on that, Key. See, what is happening since the Lancet Commission report, there has been a lot of interest in these national surgical and programs. And what I have noticed in last decade or so, there has been a mushrooming of very small private hospitals who are taking care of this surgical load at periphery, not at district level. Even towns which are smaller than a district, even there they have a couple of surgical hospitals. We are looking after the perforations, the hernias, and the fractures, everything. And lot of, but mind you, they are in the private sector. So probably their data is not being included. Last couple of months, there are a lot of people who are publishing the records of what is available at the government level about the district hospitals. And they still say that the surgeons are not there in enough numbers, the anesthetists are not there. But in the same district, there are 5 to 10 private hospitals, same district headquarter. So those numbers are probably not being counted. And what I am seeing is the number of emergencies we used to have in the medical college, say 30 years ago, has come down drastically because people don't have to travel anymore. The same facility, whatever emergencies is being done at the district level in even smaller towns. But like I told you, that's not on the radar of the government because the data is not very correct. So probably I would say the number of deaths which are being calculated would be even less. And mind you, the figures which you were quoting, they were from 2015. And since then, there hasn't been, a major study like that. What has actually happened, what has actually changed. And one of the questions which I am frequently asked whenever I travel is, what has exactly global surgery achieved? So we don't have the numbers.
Yeah.
Like
So Dhananjaya,
yeah.
the main point you're making is that there's a data problem in global surgery, and the
Yes.
data is not there, and that's your response to Key. And I think that's a very important problem. It's a problem across global health, and maybe also specific to global surgery. I just wanted to point out that that 18 million figure, even if you take Key's idea that maybe you could save 50%, and you gave some great examples there of the types of things we're talking about, fractures and perforations, bowel perforations, presumably, like think about a ruptured appendix or something.
Cesarean
And
sections. Cesarean sections.
and cesarean section. So that gives people a really clear idea, concrete idea of what we're talking about when we're talking about global surgery. So thank you for that. The point I wanted to make is that that 18 million figure, even if you cut it in half and it's 9 million, that's a huge number because the most promising things tend to save 3 million lives a year. Things in tuberculosis and malaria, things in smoking cessation with new methodologies. I've argued even GLP-1, treatment of hypertension. Those big moves, which have the highest number of potential lives saved, tend to save about 3 million lives a year. So we're talking about very, very large numbers of potential lives at stake. And that's really the point I wanted to make. So there's a lot at stake here. Now, you had that idea that about half the people, you said 5 billion people, I think, don't have access. So let's say half the people don't have access. Key, I wanted to ask you, what's the difference between, let's say, global surgery or access to surgery generally and universal health coverage and primary health care? Because it's the same numbers. If you look at the number of people in the world that don't have access to universal health coverage, it's also about 50% of the people in the world don't have access. So is global surgery really a subset of the problem of access to universal health coverage, or is there something unique? And I also wanted to ask, based on what you said initially, what's the difference between global surgery and local surgery? In other words, surgery is surgery. And what does it really mean to say global surgery or surgery and global health? We'd love your reflections on those two things.
Well, I'll start with the easy one, which is what is global surgery? You're right. Dhananjaya is actually practicing global surgery because he's a local surgeon in a place that's resource constrained. Global surgery, in my opinion, has to do with addressing the disparities in care, right, between high and low income countries. The world is not a fair place, so we need to do something more to help people who are underprivileged. So there's sort of a social justice, health disparity angle to global surgery. But then our focus is, the countries that have limited surgical capacity in some parts of India. In U.S., there are pockets of places where they have poor access to surgical care. So it really has to do with not so much income levels. It really has to do with, do we have health equity, and in this case, surgical equity. So I think that it is a subset. So we know that up to 30% of the global burden of diseases have some sort of surgical component to it. So it's a cross-cutting on all NCDs, even infectious diseases, there are surgical components to it. So it's so cross-cutting. That's why I think the numbers are so similar to the UHC deficit.
Great. And Dhananjaya, are you doing global surgery or are you doing surgery? And what's the relationship between that and universal health coverage or primary health care as you think about it?
If you let me use a cliche, it is global surgery. Global plus local surgery. See, my take is what is happening is there are three issues here. First is a specialist available there? Second is the specialist good enough to do what he's supposed to do? And the third question is, does the patient have the ability to pay for that specialization? So there are three different components. There are a lot of surgeons in the periphery who are capable of doing things. But because of the current, atmosphere of a bit of a mistrust between patients and the surgeons, they don't want to tackle serious cases or difficult cases. So those are the patients who are coming to us. What I see in my hospital is that patient will come only when he's surgically bad or medically bad or socially a demand. There is a thing called VIP in India, very important person. These patients are usually asked to go to a higher center. Diagnosis does not demand a referral, but because they throw their weight around at the local level, they are asked to go to a higher center. So these three things we have to focus. Most of the time, the surgeons are capable, but now there is a trend towards defensive medicine. So some of the patients which are being referred are those patients who could have been very well tackled, because we give master's certificate after 3 years training to about 30 people nowadays every year from my medical school alone. So we have enough surgeons. And where will they go? They all go back to their places, most of them, and open small peripheral hospitals where they are capable of tackling all these things because they have been trained to do all those things. But because of these three things, difficult surgery, medically challenging patient, or a socially challenging patient. Otherwise, most of the things can be tackled at grassroots level.
So, Dhananjaya, I liked your pushback because I said, is global surgery, is it global surgery or is it local surgery? And you said it
Local,
was both.
local,
And
local.
local, yeah, I like that. And that made a lot of sense. So, listen, where we're at so far is I think we've established there's a lot of lives at stake here. We've established that we don't know the exact number and there's a data problem. We've established the relationship that this is pretty closely related to universal health coverage, primary health care. Let's talk now and pivot a little bit to thinking about what have been the barriers and what are the opportunities to overcome them. You mentioned that 10 years ago there was this Lancet Commission. Are we making progress in surgery in low and middle income countries? And how do we know? And what have been the barriers to progress? And maybe a good place to start. I don't remember whether it was Paul Farmer or Jim Kim who referred to surgery in global health as the poor cousin,
They
or
both
words.
did. They co-wrote that piece. Yeah.
Yeah, words to that effect. And so, that maybe is an entry point to the question of barriers. You knew them both. Do you want to start with that idea of poor cousin? And then, Dhananjaya, you've written some very interesting pieces analyzing the barriers to progress in global surgery. So I'd love to hear about those too. But Key, let's start with this idea of kind of global surgery as the poor cousin of global health. What did they mean by that? What do you mean by that? Do you agree with that? Is that a thing? Is that a barrier? Over to you.
So what they actually said was the surgical care is the neglected stepchild of global health. That's the
Okay.
actual words that they use. And I think it was designed to sort of put a little poker under the behinds of surgeons saying, we're sick, we don't want to be called neglected anything, right? So and it worked. It worked. The surgeons got busy right after that. I got good news and bad news. So the good news is with the passage of the resolution 6815 calling for strengthening of emergency and essential surgical care and anesthesia as a component of UHC, one of the recommendations were to have countries develop policies. So national surgical plans. And to me, this is a huge progress. 34, 35 countries have just developed these multi-year strategies and policies to strengthen their surgical care. This is a process of doing a gap analysis, priority setting, even costing. Cambodia, I was just in Cambodia last week. They actually just launched their next 9-year plan to strengthen surgical care. Nepal's in the process. Ghana just developed one last year, I think. So that's a huge win. The problem is we still haven't seen the actual benefits at the patient level, mainly because these plans struggle to get implemented. And we'll get to this, I'm sure, a little bit later, but maybe we'll talk about it now. To implement these plans, you need, financing. And there's two financing areas. One is the investment that's needed to scale up surgical care, training, infrastructure, service delivery models. And then second is who's going to pay for per click? Who's going to pay for the operations? I mean, Dhananjaya is right. I think the public health system doesn't have to provide all surgical care, or at least a bulk of the surgical care, maybe for a subset of the population. But there's a whole another set of population where they're actually paying for these services and they expect to pay. As long as it's affordable and it's safe and it's timely, that's still filling that gap of 143 million operations. But back to the financing, it's a huge lift for countries to invest in these things. So our big barrier is how do we build financing capacity for countries to fund these national surgical plans?
So there's a few things in what you said, and then I want to get Dhananjaya's take. One is when you say neglected stepchild, that's a psychological thing. So there is a psychological issue that this wasn't really, it's so bread and butter, it's so practical, and it's so pervasive around the world. Those are exactly the kinds of things that tend to get neglected in the golden era of global health. And that's why I think we actually have an opportunity now. The poor cousin idea does get to the issue of financing, which is another aspect of the of the whole thing. It's really struck me that global health tends to focus on things that other people have as their problem: malaria, tuberculosis, etc., as opposed to, I'm thinking about this, for example, from a United States standpoint. It's those other people over there who have malaria, but surgery is so pervasive. But Dhananjaya, you've written a lot about what you see as the barriers to greater access in global surgery. Why don't you sketch a couple of those that you've written about, and if you want, stitch them to what Key was saying.
Mostly, I agree with what Key is saying. Finance is, the first hurdle. Who is going to pay for it? My take would be that there are a number of locally available solutions which do not get the credit which they deserve, and which can help our patients, our doctors take care of plenty of those problems. Barrier number one would be the local doctors thinking that they can have a solution, because they have been brought up on books from the global north which talk about all those things and which are considered standard guidelines. What happens if you don't have the equipment? How do you follow those guidelines? So you take some deviation and you solve that particular challenge, but those solutions are looked down upon. That is my biggest concern. If we have the confidence that our solutions work as well as those solutions from the global north, that is step one. So first obstacle is the belief that we can have our own solutions. Second is that if you work hard, you overcome this challenge. Last challenge is nobody cares. Nobody adopts these published solutions. So nobody adopts, nobody bothers. So the challenge is at the beginning and challenge is at the end. What I always teach is science and technology are the two sides of the same coin. Science is free, universally available. Technology is always commercially driven. That makes it more difficult for LMICs to follow. So with the help of science, we can solve number of those problems, number of those challenges. And that is where I'm always, standing on a soapbox and talking about affordable solutions, local context, locally developed. Because if we develop the solution, then you don't have to train anybody. When the technology comes, like for minimally invasive surgery, it came at a cost. Now, robotic platforms, they are hugely expensive. I have been, last few years of my service, I was chased by robotic companies. Please buy one robotic platform. I said, I need more basic surgery stuff. But the companies are interested. And, the glamour of technology is very difficult to resist. Even the patients feel that unless you are operated by the latest technology, you are not being done justice to. But science is there. We can still solve plenty of those problems. So that
Yeah.
is what I want to bring in.
Yeah, let me just stop. That's a very important barrier, if you will. And it's almost a psychological barrier. And it does tie into that idea of neglect. And, here I think is where the opportunity is. Because if you ask what's changing in global health, we had 25 years of $50 billion a year of external support going to a lot of things like HIV, malaria, tuberculosis, women and children's health, maybe not the more bread and butter things like surgery, except in those specific circumstances. But what's changing now, and you see this in all the analyses and all the discussion papers of the future of global health and the global health ecosystem, is a real shift to country leadership. My thesis is that we always talked about country leadership, but we never really meant it. And now maybe is a period where countries actually will and will have to take accountability for their own health systems. And that seems to offer an opportunity for the type of psychology, Dhananjaya, that you're talking about, which is Southern leadership, local solutions. And we'll talk in more detail in a moment about those innovations. But would you accept that idea that, on the why now front, there is a big opportunity for global surgery, because global surgery, in the sense of global surgery, goes hand in hand with local ownership, local leadership on the part of local surgeons working in their local context. So would you accept that thesis that the way global health is changing is it actually provides an opportunity for global surgery and for surgeons to work in their own context?
Local leadership is already there. This is another favorite topic of mine when I speak. The wisdom should be global. The technology should be local. So you get the wisdom from everyone. Like Key's department, they have been the leaders in this field for last so many years, advocacy and so many things which we are still learning, that we have to convince our administrators, the policymakers, that this thing is important. This we have not done enough. That is one thing. Second thing is we have to walk hand in hand and step in step. Global in my book is together. When you ask me what is global, it is together. Everyone has to come in. You mentioned a point that global health is somebody else's health, just like public health. It is not somebody else's health. It is my health, your health, everybody's health. We talk about typhoid perforations, and surgeons are very good at, opening the abdomen, suturing the perforation, putting in a drain, doing a lavage, removing the sepsis, maybe sometimes doing ileostomy, defunctioning ileostomy. But million times more important is to provide clean drinking water. So before we are talking about advent of surgery or the availability of a surgeon at a district hospital, if you provide clean water, there won't be typhoid. There won't be enteric perforation. So prevention has always been, an ounce of prevention is more than, a ton of cure. So we have to prevent these things, and that can be done only when the public health is everybody's health. You clean up your house, instead of, packing up the trash in a trash can and putting it in the proper place, you just throw it outside. You don't wash your hands. You don't teach your children how to wash your hands effectively at the school. These things are more important. Like I said, global surgery cannot be in a silo. It has to be part of, complete prevention. Complete prevention. So if number of these things come in, the global health burden will go down, and similarly the surgical care will have more chance to develop, because then there will be more money available, more finances available.
I want to talk about finance, but really, just going to follow up on Dhananjaya's a really important comment about prevention. So the discipline of global surgery is not only provision of surgical care and improving access. There's a whole prevention component to it. And I'll give you two examples. There was a resolution to try to push for folic acid fortification to prevent neural tube defects. That whole advocacy led to a resolution that passed, I think, 2 or 3 years ago at World Health Assembly. And now another group of global surgery advocates are trying to push for a head injury resolution. Prevention of head injury is part of that as well. Treatment, yes, but pre-hospital care, and then helmets and safe roads and those kind of things. So prevention is absolutely part of the global surgery umbrella. Now, getting to the financing part, Dhananjaya, you talked about the private sector. I think that is, we typically in public health focus on government provision of public health services as really a social, safety net, right? I think we've undersold ourselves on what impact we want to have by just focusing on public health systems. We've neglected this whole swath of healthcare delivery that's generates revenues. There are people who can afford to pay for these things. So we're now working with countries. When we talk to ministries of health, we want to bring in ministries of finance, not just to drive more domestic resources, help fulfill the funding commitments for the National Surgical Plan, but just looking at the entire delivery of surgical care as an economic development aspect as well. So we just did a workshop in Colombia, in Chia, Colombia, with University de la Sabana for Latin America and Caribbean countries, just this last month. And we had 12 countries there, 2 health ministers, 2 vice ministers. And the interesting thing is around blended financing. And Peter, the blended financing the structure, which has to do with donor money, whether private or public donor money, and then private capital from impact investors coming in to invest in things in these countries that can provide affordable solutions for delivering surgical care. It could be widgets, it could be facilities. And then development finance corporations coming in with de-risking money. I think we need to think about financing beyond large philanthropy, domestic resources, but we need to move beyond that and saying, how does private capital influence market shaping approach to provision of surgical care, as well as sort of that traditional social safety net?
So some of the barriers then, just to sum up, one barrier, Dhananjaya, you were really talking about mindset and mindset around local surgeons, local solutions, and some of the issues related to that. You earlier mentioned the lack of data. which leads to lack of accountability. Key, you're talking about the financing issue. We took an interesting route into prevention versus care there as well. So thinking about those barriers, and just before we pivot to talking about kind of innovative approaches for the future, I wanted to ask you both just directly, since that Lancet report just over 10 years ago, has access to global surgery gotten better? Yes, no, or you don't know?
Who
Definitely,
should
it has
go first?
become better.
Yeah.
Definitely.
Yeah,
See, originally the problem was lack of awareness. Now we are aware. Even non-medical people, non-technical people, they are aware of these deficiencies, these challenges. So there is certainly better awareness. And what has worked even better is advocacy at every level. Like Key is saying that they are meeting ministers of finance. Earlier, they won't give us the time of the day. Now they know how much prevention and how much money we can save down the line. They have realized that if we invest in surgical care today, a patient undergoing surgery later on in emergency condition will have to spend more. The government will be spending more. So now everybody is, on the same page. More and more people are realizing the importance of the global surgery. That is one thing.
that's good. But has that awareness led to greater access?
Absolutely. Absolutely. I told you the government hospitals may not have stepped up. Their data may not be enough, but I know it for a personal, and it's a fact, it's not an opinion. The number of doctors, the number of surgeons, number of anesthetists, gynecologists in the periphery has gone up by dozens, manifold,
Okay,
manifold.
that,
But
that's encouraging.
many of them are in the private sector, and they are not being harnessed. Their work is not being harnessed in the public health. They should be given rewards. They should be given credit what they are bringing to the table.
That's encouraging. Key, how would you answer that question? Since the Lancet thing just over 10 years ago, has access to global surgery gotten better? Yes or no, or you're not sure?
No, I think it has. I'll give you I give you one example, and then Dhananjaya alluded to it, the number of practitioners, right? So I'm a neurosurgeon, so we also do global neurosurgery. It's a thing, Peter. It's what it's called. And in fact, there's going to be an international society for global neurosurgery. So it's really institutionalized. But we've been tracking neurosurgical workforce. The first study we ever did was in 2016, 50,000 around the world, number of neurosurgeons. And we just repeated that study in 2023. We published it, 70,000, right? So there's been a dramatic increase in number of at least neurosurgeons. And we have to so make some assumptions that they're actually providing services. But to your point, Peter and Dhananjaya, a lot of those increases happened in the high-income countries. But in terms of countries like sub-Saharan Africa, percentage increase has been dramatic. So if you go from 4 neurosurgeons to 8, that's 100% increase. From an access standpoint, it's pitifully low. So there's some nuance there.
The number of doctors going back to periphery is increasing everywhere. The best example is COSEXA, College of Southern and Eastern Africa. They have trained, I think, more than 1,500 surgeons in last few years, and about 85-90% of them have gone back to their native countries, and they are providing service in government hospitals.
Mm.
So the amount of brain drain which used to be there earlier is no longer there. There is a greater awareness of our social obligations among the youngsters. And now they are pitching in, going back home and doing what nobody was doing earlier. It's a documented fact again.
Again, very encouraging. Now, Dhananjaya, let me just ask, you use the word periphery a few times, and that
Yes.
word means different things in different countries. When you say periphery, what do you mean? Just for our listeners.
A place smaller than a district, which is not a district headquarter, because districts are now reasonably well developed, well connected with roads, a lot of commercial activities, a lot of schools, colleges. So surgeons, anesthetists, they don't mind working at a district headquarter because there are a number of facilities for their family members. Towns smaller than district hospitals, now they have more than five nursing homes, small private hospitals at towns smaller than a district headquarter.
Okay, thank you. So, listen, we're just to recap the argument so far, and then we'll look a bit into the future. There's a lot at stake in global surgery. Whether it's the 18 million deaths, certainly not all those lives could be saved, but a lot of lives could be saved still. There's still a lot of access issues, but that seems to be getting better. You both expressed some optimism on that score. Presumably, there's still opportunities for improvement and for life saving, and so there's still a lot at stake, but the trends are improving, which is encouraging. The shift in global health with a focus on countries, country leadership, country accountability, and down to the local level might actually provide an opportunity for global surgery, which has been neglected in the past. You've both talked about barriers in data, in mindset, in finance, and these barriers are closely aligned with barriers in primary health care and universal health coverage generally. But you're optimistic, you're bullish, and so now let's look to the future. One of the things that is makes the future obviously is innovation, broadly defined. And Dhananjaya, you referred to local solutions, and I want to start there to hear about give us some examples of these local solutions. What impact do you think they can have? You've referred to it also as frugal solutions, frugal innovation, so it ties into the idea of financing. Let's start there, and then I'm going to go from there to AI, to robots, and look at the whole spectrum. But I want to start with the actual local solution, the wisdom of surgeons, and maybe, Dhananjaya, if you could start with just 2 or 3 examples. One of the things, by the way, I was blown away by is you've got a list of 100 of these
Yes,
uh,
yes.
local solutions, and I'll put that in the show notes for people who want to refer to that. But give us 2 or 3 examples of these local solutions, and what potential do you think they have to drive this move towards access to local surgery?
Okay. One of our first publications which gave us the confidence was, Apache system of prognosticating for seriously ill patients. It has about 20 odd parameters which are combined in a scale and gives you how seriously ill the patient is and the likelihood of its survival. A couple of these parameters are like arterial pH and blood gas. So 30 years ago, we didn't have any of these. So we thought, why not exclude these and include only factors which can be measured by a nurse, like pulse, blood pressure, serum creatinine. And we did it for perforation peritonitis patients, so perforation operation interval and comorbid conditions. These 5-6 parameters have enough prognostic power to prognose even without the other 15 more complex, not available parameters. So we called it Jabalpur Prognostic Scoring System. That was almost 25-30 years ago. And since then, it is being used in many hospitals. Many theses, many studies, more than 25 studies have shown that these parameters have sufficient prognostic power even in a district hospital or even smaller hospitals. So
Okay.
simple ideas, if some technology is not available, can we do without it?
So there's an example of a prognostic index
Yes.
applicable to surgery.
Yeah.
So by the way, just as an aside, some of the best prognostic indices are simple like that. You think
Yes.
about the APGAR score, for
Yes.
example,
Yes.
but that's a very good example. Give us 1 or 2 other examples, maybe
Okay.
one that's a surgical procedure.
Okay. Surgical procedure, for instance, earlier we didn't have staplers. So number of surgical procedures which need staplers they are technically demanding. Say, for instance, higher up here, just under the diaphragm, doing an esophageal anastomosis or doing a rectal anastomosis in a narrow pelvis. So we have devised techniques where if the staplers are not available, even then you can do these anastomosis. And like all old-timer surgeons, I love to sew. So it was a distinct pleasure to find those solutions when the staplers were not available to do those technically demanding procedures. So our motto became, we started getting more and more confident. Our motto became, simplify, modify, and apply. So that makes it easier. And I'll go back to, it is the belief. You don't need any other capital than what God has provided you between your 2 ears. That is all you need. Plus the belief that I can do it. Like the old adage, if you think you can, you can. If you think you can't, then you can't. So I have to give that confidence to my boys and girls that we can do it. And now with the help of telephone and mobile phones and WhatsApp, the video being shared online, now the mentoring is remotely done very easily at 2 o'clock in the morning. If somebody opens a tricky case in a small district hospital, he needs me or one of my colleagues, they can always reach out. And we are there
You've
to give
actually,
them. Yeah, we are
you've
ready to
actually
share
given
our
three,
wisdom.
3 good examples there. One is the prognostic scale or score. Second is the sewing and not stapling. And third is the telemedicine, telementorship in the middle of the night when someone runs into trouble. Those are
I can give you one more. We do lot
Okay.
lot of stomas because the patients come late, and when we repair the intestine, they are very fragile. So they are going to leak. And if it leaks inside the abdomen, then for us, it is, harbinger of death. It's very difficult to save those patients. So we make a lot of stomas, but we do not have access to stoma care. That is quite expensive. They are, disposable and expensive. So they come back to us after 3 months, many times with lot of peristromal dermatitis, lot of excoriation. That makes it very difficult for them to undergo surgery for the closure of the stoma. So one of my patients came with a, beautiful skin, shiny skin around the stoma. I said, what? How did you manage this? He said, I'm using linseed oil. I said, what? He said, linseed oil. It's a medicine which is locally available, and my grandmother told me that it has medicinal properties. I said, what? When I looked it up on Google, every generation in the history of civilization has known about the medicinal property of linseed oil. The word liniment comes from linseed oil. And a big time professor like me didn't know about it. So I'm always ready to learn from my patients. How are you managing? What are you doing it? And can you teach it to my other patients? Even today, we don't have a stoma therapist. So at any given point of time in my ward, there are 3-4 stoma patients. They teach each other how to look after the stoma with locally available, very affordable solutions. And the reason why, just let me finish one more. This is something very close to my heart.
Once you get going on these innovations, you could tell they're close to your heart. But no, go
Yes.
ahead.
So what happens earlier, we used to call them innovations. Then the problem came that everybody started discussing the semantics. How come it is an innovation? It's the same thing. You have simplified it, you have modified it. We started calling them economic solutions. But nobody wants frugal or economic solutions. Everybody, wants to go up socially. So we had a car by one of our very big companies, Nano. It cost 100,000 rupees. And they publicized it as the cheapest car in the world. Cheapest car in the world. But people didn't want to buy it. They didn't want the cheapest. They didn't want the neighbors to know that they are poor and they cannot buy a more fancy car. So now I have shifted to affordable or cost-effective solutions. So that change I had to make from innovation to economic to frugal to now I talk only about affordable solutions. Okay, sorry.
That's a, that's
Over
a
to you.
great set of examples, and it just shows you. I mean, I take your point about the marketing and what you call it, and but it does
Yes,
show you that innovation doesn't have to be complicated. It can be a part of service delivery, and you just have to be humble enough to learn and innovate, as you were very well illustrating. And by the way, just for people who listening may not know, a stoma is when you take the bowel and you attach it to the outside
open the
because
bowel
you've had
outside.
to
Open the
you
bowel outside.
open the bowel outside
So
because you've had to resect
part
a
of the
part of the
intestine before that gets rest. A part of intestine distal to that gets rest because the food and the fecal matter doesn't go there.
right. Good. So that's I think the base case, which is those affordable solutions, cost-effective solutions. I would call them innovations, but I could see that I can understand your logic in what you said, and it's great to see you so passionate about it. You know, surgery has always been a discipline that's innovated in that way. You're there in the middle of the night, something's not hooking up, you have to
Yes.
find a different way to hook it up. And so you're really tapping into a long tradition of innovation in surgery there. So, Key, take it from there. That's not the only type of innovation that might exist in surgery. And let's talk about other types. And I also want you to talk about robots, which many
Sure.
people are talking about. And I don't want to set this up as kind of affordable solutions versus robots, but let's layer on the different types of innovations that might be available. So over to you.
Yeah. No, I was just, as Dhananjaya was speaking, he's got so many great ideas. But surgeons typically are not entrepreneurs, right? We just kind of, here it is. I wonder we should pair you up with a entrepreneurship, training program or another team. They can help some of these ideas and monetize it and then maybe even scale it. I mean, that's my immediate thinking on that. Okay, let's talk about, what's happening in technology today. We're in an age of disruption, in healthcare. There's no question about it. Technology disruption. AI, there's a couple of things that I think are tantalizing to think about from an AI standpoint. One is, can we use AI to develop trainers right? Actual trainers that can talk and answer questions in real time, and that would be a force multiplier if the number of trainers are limited. But I have a real life example of an actual AI app being used. So I advised on a research project from one of my former fellows on 5 West African countries. It's funded by OpenAI, and they developed a proprietary app that actually listens to rounds, right? And then talk about the patient's symptoms and things like that, and generates recommendations at the end of each round. And so now they're doing a multi-center trial, pre-app and post OpenAI app. And I'm sure it's going to show some positive impact. Once we have that evidence, we can potentially see that kind of stuff really just being adopted widely, right? Because you need evidence first. I think from a clinical care point of view, it can improve quality of care, no doubt about that. Let's talk about robotics. Right now, the 800-pound gorilla in the robotics industry is Intuitive Surgical, which makes Da Vinci robots. That is not a robot. That is actually a mechatronic device, which requires a master and it's a slave device. The surgeon actually does the operation, and it's really a mechanical arm that's small. That said, we're not too far away with actual robots doing surgery, Peter. I happen to sort of agree with Elon Musk. I don't know if I can say that here. He says, he thinks robots will replace surgeons in 3 years. That's a little ambitious, but I think we're going in that direction. There have been studies that showed that robots can perform autonomous. You push a button, say go, and start to finish gallbladder surgery in pigs. So it's a matter of time. Human beings can see 4 shades of gray. A robot can see 64 shades. I mean, they can see better, they can move better. It's not going to replace surgical care, but I think it can really be used to be physician and surgeon extenders. But here's the caveat, right? It's got to be affordable, right? You can't just make this a high-income country for the elites only. There's a responsibility from governments to try to and really finance people to see we can at least devote some of the resources and regulations so that it's available for the masses.
That's very interesting. Yeah, Dhananjaya, what's your take on AI, which you've written about, and
No,
robots, and put
no, no.
that into context for us?
We are no strangers to AI. And with Professor Mayol from Madrid, we have made a chat GPT for affordable surgical solutions. It's available on a click on a phone, and you can ask your question. My intestine is like this. My patient has this type of low blood pressure. What should I do? It'll give you options. So AI is there, already there, and we have to tap it to the best of our abilities. And as far as about it replacing surgery, it is certainly going to assist surgeons and LMICs more than what they have received till now, because help at fingertips is going to be crucial. And we are talking about those surgeons who are operating in the middle of the night in a small mission hospital, maybe in the middle of nowhere, in the jungle, in the forest. So if they have access to such things, it is certainly going to be very helpful for him and for the patients.
And robots?
Robots may be another few years down the line, because we are still some distance away, but it's very exciting. And everybody wants to be on the bandwagon of what is latest. But like he said, it has to fit in your pocket. The cost. The surgery has to be fit for the patient. Patient has to be fit to undergo that surgery. And the cost of that surgery has to fit in his wallet. Everything has to fit. You cannot have a small operation which requires $100,000. There has to be democracy. There has to be socialism. I don't know what you want to call it, or equitable. It has to be available for the person at the grassroots level. Otherwise, it is not meaningful.
So that's a good point at which to pivot to looking, let's say, 10 years from now. So where we're at so far in the argument is there's a lot at stake in global surgery. Global surgery is really local surgery. There's some barriers to access, and there are access issues like there are with universal health coverage, but there's some barriers. Maybe foremost among them is mindset, and then also finance, data, very similar to the barriers on universal health coverage generally. But you're both optimistic that there's been progress. There still remains progress to happen. You both see innovation as a pathway to that progress. And That can be affordable solutions like you're describing, Dhananjaya. It can be AI, and you've both given some great examples of, or it could even be technologies, robotic technologies. You've got a little bit of disagreement about the timing of that, but that's okay. And so you're optimistic, you see progress, you see innovations. So let's look 10 years from now. It's 2026. Let's say in 2036, 40. What do you see for global surgery? What would you like to see? What do you think can be achieved? And what's your final message to our viewers and listeners in regard to global surgery? Dhananjaya, do you want to
Yeah,
start off?
yeah. My wish list that affordable solutions will become more acceptable because they are not certainly not inferior, and ethically they are far more superior because they are making things available where they are needed. So I would love to see that. Plus, global surgery, Peter, is a very unusual discipline. Global surgery and global health, both these disciplines are working towards their own extinction. The day the differences in health care available at everywhere disappears, these two branches will die their own deaths. So the most remarkable thing is that we are, whoever is working in global health or global surgery, we are working towards this extinction. And I would love to see that in my lifetime. So that is my wish list. Plus, more accountability, certainly better data. And I wish younger colleagues like, see, I was drawing a salary of the professor and head of the department, so I could devote my extra time to global surgery. What about a young chap, young girl who wants to come in? There is no actual recognition of the work in global surgery financially. They have to be paid. You can't depend upon grants. That grant business, if she or he is writing half his or her time to writing a grant, or the professor is scouting around for a grant so he can pay the fellows, then that is going to defeat the purpose. They have to be free from those financial issues so they can focus only on, like I said, all the capital you need is here. So you have to utilize that capital for thinking for solutions and teaching others, inspiring them, making them more confident, making them believe that you can do it. And that is what we have to do it. So global surgery, global health, lot of departments are doing it, something which they do when they finish their clinical duties, teaching duties, research duties. They have to be better recognized, not only in their CV, but certainly they should be paid. Especially the younger guys and the girls, they have to be paid. Otherwise, they come for global surgery fellowship or global health fellowship just for a couple of lines in their CV and maybe on authorship list of a couple of papers. There has to be more to it. So it has to be recognized. It has to be acknowledged, their work financially. It should not only be spiritual. It should not be an obligation, spiritual obligation that you go and work. It should work. It should be a profession, not only a vocation. So I hope to see it in next 10, 15 years. That is my wish list.
That's great. And by the way, let me just follow up one thing there. You mentioned gender equity issues, and you were talking about female surgeons. How does that look now? Is there gender equity in surgery in low and middle income countries? Is that also on your wish list?
Much better. Much better, much better. And in some of the surgical departments, I know half the residents are girls, and they are much better than the boys. I have to say this. They are more sincere. No, it's a fact. They are more sincere, more hardworking. And like the old joke goes, they have to be better than the boys, and they say it's a piece of cake. It doesn't mean much. We are better than the boys. So a lot of girl students are coming now, and they are performing very well. Very well. That their confidence has to be seen to be believed. I am proud of those girls, better than most of the boys. Very smart girls, very articulate, very good surgeons, very caring, very compassionate.
Great.
It is already on its way.
Yeah, I'll just say this: at the program in global surgery and social change, we train future leaders in global surgery, and I would say more than half of our fellows are women. So they make up the majority of our fellows now.
That's great to hear. What do you see in 2036 and 2040 for global surgery?
Well, mercifully, you've given us another 10 years. It's not another year from now. Because, people, it's been 10 years since Lancet Commission. And I agree, we've made much progress, but we're not really going to see the impact, right, on the ground. I'm hoping in another 10 years, we'll actually have a world that's much more fairer in terms of surgical access. How will we know that? I think we'll have to do some additional, research on that. Compared to what it was in 2015, hopefully in 2035, we'll be able to demonstrate that, things are much better than it is in 2015.
That's
Can I
great.
come in for one more comment?
Yeah,
We
No,
sure.
spoke
and I want to
about
say this,
yeah
Dhananjaya, before you play
yeah
it. And then in
we spoke
2035, Dhananjaya won't write any critical articles about us.
so
That would be a good future key. It's kind of fun when he does, but okay, whatever.
I know Key is using that poker to poke at my backside. Okay, I'm sure I'll be up to it. I'll be up to it. What I wanted to say was we spoke about global surgery being the orphan child or the neglected child of global health. Another thing I would like to see is that these affordable solutions, which I keep harping on, forgive me, affordable solutions will not be the orphan child of global surgery. They'll have better acceptance and they will be given their due place. There is a thing called reverse innovation. Number of ideas which originated from LMICs, they are being used in the global north. But like he said, we don't know how to market them. We don't know how to escalate them. One of the best example is use of mosquito net for hernia repair. Hernia repair is done with a mesh. Mesh is expensive. You can just use a nylon mosquito net. Just sterilize it and use it. It has been shown in numerous trials that it is as good as the commercially available mesh, but nobody is using it in the West. Experimental studies have shown, animal studies have shown, clinical studies have shown. So these reverse innovations will become the norm rather than an exception. So we'll no
Interesting.
longer be the poor cousins or the neglected stepchild of global surgery. That is my
Interesting.
final wish.
Interesting. And I do want to come back to one last thing that I was asking about because I've been reflecting on it as we've been speaking. And it ties it back to what some would see as a crisis in global health, what some would see as an opportunity in global health. The drastic drop in development assistance for health, which was, $15 billion a year in the year 2000, went up to about $50 billion a year in the twins, peaked at $80 billion a year in COVID, and now is dropping. Surely it's less than 30 billion and falling fast. So there's a big change in the financing, in the nature, in the ecosystem of global health. And everybody's talking about ecosystem reform. What I wanted to ask you is, does that provide a greater opportunity for the types of changes you were talking about in global surgery? Is it actually going to be easier in 2026 to make progress on global surgery than it would have been in 2016? Because everything is in flux, everything is in play, and many of the issues you were talking about actually correlate very much to a focus on countries, on accountability, on local leadership. So I just wanted to ask you that final question. Do these huge translocations in global health that we're experiencing now, does that make it actually easier to make progress on global surgery than it would have been, say, 10 years ago when we had what was really, I would argue, kind of a rigid system focused on a few things, very stable and squeezing other things out?
Yes, sir. Certainly. It's a wake up call, a reality check. You can't depend on external assistance. You have to rise to the occasion. And if we don't do it today, and if we will not do it, then who will do it? So the global south has to rise. Like I said, let's use all the wisdom from the global north, but let us not depend on them. There should be dignity in our own work. From dependence to dignity, we have to rise. We have to take, and we are not partners. We are actually, when someone says, what are you bringing to the table? So for global health and global surgery, we don't have to bring anything to the table. We own the house in which the table is there. It was the global north which was bringing something to the table. So it is our house. We have to rise. So it's a reality check. And if we don't do it today, then we are never going to do it later on.
And that's exactly what you used some beautiful words, and that's exactly I think where global health overall is heading, which is
Yes.
why I wanted to ask that question, and you enunciated it beautifully. Key, what do you think in terms of the opportunity now compared to 10 years ago with the shakeup in global health that we're experiencing and all the global health ecosystem chatter and reform?
Yeah, I mean, the overseas development assistance is drying up. And not just US, but all the other donors too, right? There's always going to be a group of countries that are the poorest and the government is just unable to provide the social network. I think those countries are like any other charitable activity. We need to consider them charitable countries and we have to provide assistance. But then once we go beyond that, you have to question whether or not if you provide external assistance, to what degree does that take the pressure off of the government, right? That's one risk. Now that's gone. Now the pressure's back on the government. But the other thing is the donors typically have an agenda. It's usually given as an extension of their foreign policy or certain diseases that they want to see stay in the continent and not come to the United States. Now they're sort of freed from all that. So I really think it's an opportunity. So it's a stress in the system. If properly met, it could really be a boon and really make countries become much more independent and take ownership.
Great.
One more point, greater opportunity for South-South cooperation.
Yes.
Things are easier. Contextually, things are similar. Culturally, things are different, similar. So South-South collaboration, instead of looking at the global North, that's another very logical answer to this query.
Great. Well, thank you guys very much. It was super interesting to talk to you and work through those issues, and really appreciate your insights. I think it's already less of a poor cousin, already less of a neglected stepchild, and with the work that you're doing, the men and especially the women leaders that you both were talking about, I think we can have confidence that things will be much better in 2035 or 2040 than they are today. And you've sketched the opportunity space and the paths forward very well. And I appreciate it. And thank you very much. Thanks for coming on Global Health Insights.
It's pleasure.
Thanks, Peter.
Pleasure.
Bye-bye.
Take care, Peter. Bye-bye.
Bye-bye,
Bye-bye.
Dhananjaya.